Good afternoon, colleagues. This is a PANCAP webinar on COVID-19 prevention and management in children. I am Dr. Shanti Singh Anthony, Knowledge Managed Coordinator for PANCAP, the Pan-Caribbean Partnership Against HIV and AIDS. According to the World Health Organization, in its 9th of April situation report, there are more than 1.4 million COVID-19 confirmed cases, with more than 82,000 cases confirmed as the one-day total for yesterday, April 9th. Indeed, the numbers are quite staggering. In relation to children, however, I think it's quite fascinating that children seemingly are faring well in this pandemic, while on the other hand, many are asymptomatic with the potential to transmit. This afternoon, we have two experienced physicians, pediatricians, who will share their expertise and experiences in managing COVID-19 in children. Before we proceed, a few housekeeping notes. Your mics are muted, so if you have any questions, I ask that you type these in. We'll take your questions at the end of both presentations during a question and answer segment. The webinar, we're recording this webinar and we'll share the recording on PANCAP's website for the benefit of the wider partnership. Again, I encourage you to type your questions in as the presentation progresses. Our first presenter this afternoon is Dr. Hardat Persaud. He is a pediatrician for more than 25 years, has served as the head of pediatrics for the Georgetown Public Hospital for many years, before fully transitioned to private practice. He is the pediatrician at Woodlands Hospital in Georgetown, Guyana. Dr. Persaud also serves as a senior lecturer and examiner in pediatrics at the School of Medicine, University of Guyana. I now hand you over to Dr. Persaud.
Hi, good afternoon to all. Because when you interface with the parents and children that come to your office, there'll be tons of questions that you'll have to answer. Me, I think the key to our success in this part of the world, where we don't have a ton of money to spend on testing and fancy equipment, the key to our success in fighting this virus will be prevention, in the very primary management of the COVID infection. So without losing much more time, I would like to start with my first slide. This is what a very simplified version of the COVID looks like. The spikes there is what makes it very virulent. Those are the spikes that it will use to enter to be the fortress, but we have found the key to this. This is the weapon. This is the RA. This is what the virus needs to use to multiply itself and spread all over the world. So if we were to look at the index of infectiousness of the COVID virus, we'll see that by far, it's nothing compared to measles and smallpox, and even things like Zika. However, even though the index of contagiousness, that is the number of people who can be infected by the index person or the first person, is relatively low, we'll see that we can have some we'll see that we can have some massive mathematical formulations to deal with. So if we were to look quickly at measles, we see that one person with measles is capable of infecting about 18 persons. Whereas if we go right down to the other end of the spectrum here with things like Ebola and so on, it's much less. However, when we look at COVID, for example, and if you were to do a quick comparison with measles, COVID, Zika, and the seasonal flu, we'll see that COVID is by far less than measles and Zika, and is just a tad more infectious than the seasonal flu. But do not be fooled, because that tad more infectious mathematically can translate to something like this. Now, I want us to take the example of that ship, the Diamond Princess. There was an outbreak of COVID on that ship where nobody was suspecting. And as a result of that, the virus was able to multiply unimpeded. So they had a good mathematical formula that they could have worked out from that ship on how the virus, what was the index of contagiousness. Now, let us just compare simply the flu, the seasonal flu, which is 1.3, meaning that one person who is ill with the flu will pass on the flu to a little more than 1.3. Whereas with COVID, we're being very conservative here. It's more than 2. It's about 2.3, 2.5. But if we take for mathematical purposes just 2, we're being very conservative here. We can see in a matter of 10, in just a matter of 10 progressions, 10 tiers of infection, that we have a huge number of patients going into the thousands. Whereas with the seasonal flu, it would only be in the dozens. Now, what is very concerning is that with the flu, the hospitalization rate is just about 2%. But with COVID-19, it can get as high as 31%. Now, our hospitals all over the world, even in the developed countries, weren't prepared for this. And if we were to look at the fatality rate, we'd see that COVID is about 1 to 3%, whereas the flu is just 0.1%. So this is a tremendous difference between the flu and COVID. Now, a lot of people, when COVID broke out and became known, a lot of prominent people went on TV and said, oh, this is just like the flu. We're going to handle it like the flu. And indeed, they were right in a way, because if you look at some of the symptoms here, you can see that both the flu and COVID hit by fever, cough, body aches, fatigue, and of course, both can progress to pneumonia. So what's the big difference? Well, there is a big difference, as we will see. With the flu, expressions of the disease shows up very quickly. In a matter of a day or two, the person begins to feel sick. As you can see here, the person begins to feel sick, and the person stays away from work, from school, takes bed rest, and is kind of like going to isolation. With regards to COVID now, the incubation period can be as much as 12 to 14 days. Most people will feel sick around 5 to 7 days, but we can go as far as 2 weeks until the symptoms begin to show. And this is where a huge danger lies, because this person who is asymptomatic could be shedding the virus all of this time here. And that is why this pandemic is so widespread. Now, it's estimated that we can have between 20 and 60% of the world becoming infected with COVID. And if you look at the background there, you'll see the red ones. This is the index case. These are the red ones, are the ones already infected. And the green ones, as you can see here, are the ones who are yet to be infected. And the main reason for this is because there is no inherent immunity for COVID-19. This is a novel, this is a new virus. This is the equivalent to what happened to the Indians in the South American jungle when they were first introduced to influenza and smallpox. The death rate there was worse than machine gun fire. So the world is experiencing a new virus. There is no inherent immunity, no species immunity. And unlike the flu, that is why we should not be comparing it too much with the flu. Unlike the flu, a lot of people have immunity against the flu. A lot of people have had their flu shots. So, unlike COVID, we have some form of herd immunity with respect to the flu. Now, one of the main reasons for what we're trying to do to prevent and asking our children also to do the same is to adopt a stance of social distancing. And social distancing, as this is a lovely diagram I managed to find. I'm sure you'd have seen it, but we could probably go through it together. It shows that if a person is infected and they're unsuspecting and they do not take any form of precautions, within 5 days, there are about 2 or more persons will be infected. And in a matter of 1 month, there'll be more than 400 people infected. This is exactly what happened on the cruise ship, the Diamond Princess. If a person is more or less aware and socially very responsible, quite responsible, and decides to do like, on-off social distancing, of course, the infection rate will be less. In a matter of 5 days, there'll be fewer people, and in a 30-day period, there'll just be about 15. If the person is more conscious of his or her social responsibility and decides to most times not expose and observe social distancing, then as you can see, it's a much less infectious rate here. So what we are all trying to do right now, the entire country, the entire region, the entire world, is try to get as close as possible to 100% exposure and 100% observation of social distancing. The whole idea is to get the RO, or the rate of infection, to less than 1. So in a shutdown situation or lockdown situation, we can actually make the virus peter out of society, because the virus doesn't really, it's a bit unnerving to hear that the tigers in the Bronx Zoo got infected with corona. Hopefully it won't be hiding out in the wild in animals. But for the time being, if we can exercise good social distancing, we'd be able to bring down the rate of infectiousness to less than 1. Now, social distancing, as you can see here, those in the squares are people who have isolated themselves successfully. This is the equivalent of the flu vaccine. Imagine a flu scenario where these ones in the red, infected persons, are surrounded by people who have had their flu shots or who had the flu sometime in the past. This is exactly what is happening. With social distancing, we are creating an artificial scenario of immunized people in inverted commas. So that's the science behind social distancing. Now, this is a mathematical conjecture. We really can't take this 100%, but I mean, people who did some maths have been able to come up with something like this and showing you that if a short lockdown takes place, then we'll have a resurgence. If you do 2 short shutdowns, you're not going to achieve much. You're going to have another resurgence. So the key is to have a long enough shutdown. Now, I don't want you to take this 49 days here as being the gospel. A long enough shutdown. And the statisticians and the medical people and the epidemiologists are the ones who are going to determine how long, what is the optimum shutdown for our region as a whole. Now, in this slide here, we're going to look at how the virus survives in the environment and what we can do to combat this. Pay attention to the last line here. Remains viable for 3 hours in aerosols. Now, in the beginning, we were thinking about COVID as being a heavy virus, heavy particle, and the moment you sneeze or cough, in a matter of minutes, it will fall to the floor, and that's the end of it. But we have gotten wiser, and the hard way too. We've gotten wise in realizing that this thing can actually suspend itself in the air for hours, for 3 hours. Of course, it's not like measles or chickenpox, but 3 hours is significant because you can walk into an atmosphere and you don't know who sneezed or coughed just before you, or an hour before you, or 2 hours before you. So now that we have this information, what are we doing about it? This is a diagram to show that if both parties are not wearing a mask, then the infectious rate would become very high. If one person is wearing a mask, It still is very high, especially the person who's coughing or sneezing, the infected person. If the infected person is wearing a mask, of course, it's going to be less because most of the virus will not be able to cover a distance. And if both people are wearing a mask, of course, the infectious rate will be much lower. So what is the conclusion? We should all wear a mask. I know that a few months ago, or maybe a month ago, they were talking about, oh, you don't need to wear a mask, only if you're in a high-risk situation, and that sort of thing. No. If you take the Czech Republic as a good example, in a matter of 3 days, the Czech Republic procured, manufactured 10 million masks and made it mandatory for everyone to wear a mask. And they had very good results. So this thing about a mask and a stigma, you know, it's an Asian thing, and you know, in North America we don't have to wear a mask. All that's gone through the window. Wearing a mask is no longer an Asian thing. This is a good example of people who are complying. People who are very aware. These are some kids that came to see me recently, and if you, as you can see, they're all wearing a mask. Even the infant is wearing a mask. Let's examine how this virus manages to stay in the environment. I promise that I'll not talk much about the effect of the climate and the temperature and so on. I think it's better if we go with the worst case scenario and look at and take these figures into serious consideration. As you can see, paper, dry paper and tissue, 3 hours. Copper, 4 hours, cardboard, wood, cloth, it's all there for you to see. I want you to pay attention to paper money. Now, we use a lot of paper money. You go to the minibus, you get your change. You go to the grocery store, you get your change, and that virus can stay on that money for 4 days. Maybe because the paper money is so much handled that it has a layer of fat in it, oil, and the virus likes to stick to the oil or the fat. So, look, pay attention also to the outside of surgical masks. It can stay on that surface for a long time. So that's why it's important when you're taking off your mask, you don't hold the mask itself. You try to hold the thread. You try to hold the back part of the mask, the lacing part of the mask. You try to hold that and take it off. And of course, you can't wash a surgical mask, but the cloth masks that people are very good now at manufacturing, you can wash those with a detergent. So with respect to the number of days and hours that this virus is capable of staying alive, only waiting to be to get into your respiratory tract, we should examine the other aspect of prevention, that is using soap and properly washing. So this is the science and magic of soap. Now bear in mind, the best soap are the cheapest ones. The most horrible smelling soap is the best one. That's the one that can cleave the virus. So don't run away with buying the best smelling soap. Any soap will do. Dishwashing fluid will do. Any detergent will do. Because what a detergent or soap does is to strip grease. It breaks the fat globule. And as we can see here, on your skin, there's a film of fat or oil. And the virus can easily adhere to that film, as you can see here. Now, when you mechanically wash your hands, you are not able to get this virus off of the surface of your hands so easily. That is why you need to soap, and you need to soap for at least 20 minutes because, 20 seconds, because we need that 20 seconds for the actual cleavage of this capsule to take place. As you can see, the soap has to act on the lipid shell of the virus and break it up. That is how we can destroy the virus. So not only are we mechanically removing the oil film from your hands and washing the virus into the sink, but at the same time, we're using our 20 seconds of exposure to soap to help crack the envelope of the virus. Hence, hand washing cannot be overemphasized, and the timing in which this is done. Now, there are lots of formulas in how you can calculate 20 seconds. And I like to say that The easiest way for children to learn that is to say 1 banana, 2 banana, 3 banana until you reach 20 bananas. This is a slide that I made from a very smart doctor, and this is, you know, they say necessity is the mother of invention. Any doctor will know that the biggest danger that you can do for yourself is to touch your nose, mouth, eyes with hands that weren't washed properly. So this is a doctor who decided that if you put some tape at the back of your elbow, every time you try to touch your face, it becomes uncomfortable. So you're able to flex your elbow enough to do your routine work, but the moment you try to touch your face, you're reminded by this contraption here, very simple contraption, that you should not be touching your face. Now that comes to another question of the mask. Why should we be wearing a mask? Well, if you're not in an exposed area, like a hospital, a waiting room, or a procedure room, or somewhere, a crowded place, a subway, it's still good to wear the mask because the mask does not allow you to touch parts of your face. And it's a reminder that we're dealing with something, you know, even if it's difficult to breathe through a mask, it always reminds you on how much you should be vigilant. Okay, now why are we doing all of this? Why are we isolating? Why are we social distancing? Why are we not touching face? Why are we washing hands? The whole idea is to flatten the curve. Now, most people already know what is flattening the curve, but I'll just go through it quickly because I know there might be a few lay persons who are on this seminar. And the whole idea of flattening the curve, which is the blue curve here, the whole idea of flattening the curve is to push the infection down the road, meaning don't have all of the infection at one go in a few days, in a short period of time, because when that happens, the number of sick people turning up at the hospital, very sick people turning up at the hospital, is more than the hospitals can take off. And although there are a category of people who will die anyway, there's still a category of people who need some help with a bit of oxygen, with some intravenous fluids, and so on. They would be able to they would be able to get some help from the hospital system. So it's very important that we try to slow the infection rate to such an extent that we can achieve this flattening of the curve. Now, a bit of seasonality has been noted with coronavirus strains. This is not COVID. These are other coronaviruses that were studied over time in the various years, and there's some kind of seasonality in their infectious rates. If you notice, the winter months they seem to thrive. In the summer months they tend to peter out, and then they resurge again, and so on. We're not going to take this as a savior for ourselves, that we're living in a tropical country and we're not going to have this this scourge. No. We have to go with worst case scenario. So how true this is will be reflected in the southern hemisphere, where there is winter right now. So if they start to get surges, we'll see that yes, this is true, and we're gonna just, if the heat and the ultraviolet does have a good effect for us, well, that's our good luck. So just quickly on the presentation of our pediatric patients, we can see that it is more or less a little more varied. The patient most times will come down with a cough and a fever, a dry cough and fever, and there will be some weakness, lethargy, body pains, myalgia. And in pediatric patients, fortunately, we don't have much complications that leads to like pneumonia and ventilation and all of that. But bear in mind that diarrhea and abdominal pains can be one of the symptoms, signs and symptoms. And here it is in terms of percentages: fever, 99%, fatigue, dry cough. These are by far the most. Of course, children are very well known. Once they get sick, they don't eat well. So, all right. So the younger the age, this is considered a high-risk situation. If they have underlying pulmonary pathology, for example, if they have asthma and they have chronic bronchitis and so on. In our part of the world, we don't have cystic fibrosis so much, but if they have immunocompromised condition and if they have any other co-infections with, for example, RSV infection is very detrimental when it's combined with COVID. If we look at the cases, why we're doing this seminar today is because the main reason a lot of emphasis is being placed on adult medicine because that's where the mortality is, and because children not having so much morbidity and mortality, we're not getting so much literature coming out on how to manage these cases. And that's why I'm happy we have today Dr. Narendra Singh, who will be dealing with what happens when our child gets sick enough to be in a hospital. So this is just another slide. We're coming to the end that shows that indeed very few cases are in the critical range. Now, what is our aim? What is our aim with all of this? In our job as pediatricians, as general practitioners, as teachers, our job is to inform the public, make it simple, teach them what is the right thing to do, what are the preventative measures that they can do at home, and the whole idea is to try and get this 60% as close as possible to 20% or less. So that is our job. All right, so I just want to end off by this slide, which says that the child is replying that we are doing our part by staying home. So children, now is a good time to be with your child, watch movies with them. I had a lot of questions about getting children to wear masks, but I don't think that should be a problem. You know, you can watch Zorro with them, you can watch Lone Ranger with them, you can just glamorize this mask business and so on. Once we have children on board, once we teach them why this is happening, and that, yeah, that would be great. So with this, I'd like to end. Thank you very much for listening.
Thank you very much, Dr. Hardat Persaud. Very interesting and comprehensive presentation on managing children. I encourage our participants to type your questions in. We will take them at the end of the second presentation. So presenting now is Dr. Narendra Singh. He's a pediatric intensivist. He is also an associate professor of pediatrics at McMaster University. Dr. Singh is a fellow of the American Academy of Pediatrics and the American College of Critical Care Medicine. He is currently the program director for the postgraduate program at the University of Guyana and an external examiner for the University of Guyana in the undergraduate medical program. Dr. Singh is also the president and founder of Guyana Help the Kids Foundation and has been instrumental in improving pediatric care in Guyana. He has authored over 100 peer-reviewed articles and abstracts and has authored a handbook in pediatric critical care. I now turn you over to Dr. Singh, who will present on management strategies of the COVID-19 children.
Good afternoon, everyone, and thanks, Dr. Singh, for the introduction. I would like to wish everyone a happy Good Friday, and I hope that now that you're all home, that you're able to spend a wonderful weekend with the family, Easter weekend rather. Before I get started, I just want to give you a bit of a personal perspective and a little bit of my own experience. So I've been a pediatric intensivist for about 30 years. And every morning I drive into work, I am quite comfortable that I'm able to manage the patients in the ICU. And if I'm not able, you know, I recruit some of my colleagues to help me along the way. I started my shift in the ICU yesterday. We have one COVID patient in my ICU that's on a ventilator. And I have to tell you, for the very first time in my 30-odd years of doing pediatric ICU, I'm scared. I am scared for myself. I'm scared for our nursing staff. I'm scared for our frontline providers. I'm scared that I might actually take this virus home to my family and my mother, who's 80-something years of age. Should I be scared? Yeah, I think I should be scared. Should we all be scared? Absolutely. But I don't think we should be scared to the point of panicking. I think it's important for us to be scared, but at the same time, use that fear to be constructive, develop policies and procedures, be proactive in making sure we guide our frontline staff through those policies and procedures, make sure we invest in resources to protect the frontline staff. I see it all the time, whether it's Europe or Canada or the United States where I work, there's not enough PPEs out there. And one of the things that we can do to protect our frontline staff is make sure that we invest as much resources, because the frontline staff are the best resource that we have and we have to protect them. So I am scared, guys, and if you're not, you should be. Take care of the kids, but beware of the kids. This is a good news, bad news situation. And
sorry to interrupt you, Dr. Singh, but we're not seeing your slides.
Should I then share?
Sure, please do.
Sorry, go ahead. Bear with me. Dr. Singh, on the, see, where is that? Are you seeing that as yet? There we go. Are you seeing the slide?
Perfect.
All right. So I apologize for that technical glitch. Move that off a bit here. Yeah, so if you're able to see the slide, the statement that I made is take care of the kids, but beware of the kids. So this is kind of a good news, bad news story. And indulge me for the next couple of slides. I'd like to explain a little bit of what I mean by that. I'm having trouble advancing the slide. Okay, let's try that. Yes, so this slide is extracted from some data that just came out on Monday about the pediatric experience here in the United States. And a couple of things to notice here is they found that from February to April, they had about over 2,500 pediatric patients, of which 3 of them died, with a case fatality of 0.002%. That's the good news. The bad news is when you look at the adult population, the case fatality rate for the COVID positive ones was 3.4%. Now, we as healthcare providers, when we look at the literature, we see that as many as, depending upon the jurisdiction where you looked at, as many as 10 to 28% of healthcare workers are getting infected. There's not a lot of literature in terms of how many healthcare providers have died, but as many as 250 have been documented as having passed away as a result of the COVID virus. In Italy alone, they said that 70 doctors have died as a result of the COVID. So in the pediatric population, there's good news. In the adult population, not so much. This is a brief summary of the experience within pediatrics in China. If you look at the data, you'll see that 51% of the cases are very mild, 39% are moderate, 6% are severe or critical, and 4% have no symptoms whatsoever. This study I talked about in the United States that just came out on Monday showed that there were over 2,000 cases documented, and of the 2,000, only 147 rose to the level of requiring hospital admission. What was of note here is 62% of those patients that were admitted were infants. The graph on the left shows the ones in black are all the ones that did not require hospital admission. In the darker blue, the ones that did require hospital admission, and the lighter blue are the ones that required ICU care. This is a slide that I got from a group of pediatric intensive care units that are submitting their data throughout the United States. As you can see, not all of them are submitting data. But of the ones that have submitted data, there are 138 COVID positive cases, which includes one in my ICU. There are 3 confirmed deaths, and the PICU days is 604. What is of note as well is that if you look at the comorbidities of those patients that are being admitted, the ones that had moderate to severe comorbidities accounted for 30%. The ones that had mild comorbidities accounted for 35%. So the bottom line is 65% of the patients who get ill to require pediatric ICU admissions had comorbid conditions. And that is something to note if you do have that population of patients within your practice. What is the takeaway message from the data I presented to you? Very few kids get severely ill. Infants and kids with chronic illnesses, as I mentioned, are at an increased risk. But the bad news here is that despite the fact that they are mild cases, kids are actually the perfect vectors for transferring the infection from individuals to themselves to others. They don't get ill, but they act as the vectors. So it's important that we keep that in mind. One of the reasons that kids are the best vectors is they have mild illness or they're asymptomatic, which means we don't know they're ill and therefore we don't necessarily isolate them. 2, if they are ill, it's next to impossible to isolate a kid and equally difficult often to keep a mask from them. Thirdly, what they've shown in some of the studies in China and in Europe is that kids tend to excrete the virus for a much longer period of time in their nasal secretions and their mouth. Plus, they're identifying cases where the virus is actually in the stool as long as a month after the kids have resolved from the infection. So for all those reasons, despite the fact that kids do not get very sick, they need to be taken into consideration in the big picture of this pandemic because they act as the perfect vector.
Okay, colleagues, my apologies, but I think we've just lost Dr. Narendra Singh. I think he's just disconnected from the webinar. He will be with us in a few minutes. In the meanwhile, I'll go ahead, Dr. Persaud, if that's okay with you. I'll go ahead and I'll start reading some of the questions that we have here, and you can proceed with responding to some of these while we wait on Dr. Narendra Singh to get back online. So here's a question for you, Dr. Persaud. Can you please, on one of your slides, you referred to the acronym RVR. Can you please explain and clarify what RVR means?
It's a respiratory virus.
Okay, so the second question, Dr. Persaud, are you still here with me?
Yeah, I'm trying to pull up back the presentation. I took it off.
Okay, the second question is... Yeah, I'm still checking for Dr. Narendra Singh. The second question is, the CDC and AAP have previously stated that cloth face coverings should not be placed on young children under age 2. What practical guidelines should health practitioners recommend to parents in this instance?
Well, constant supervision. I mean, they're thinking about choking and all of that, but I think when the risks outweigh the benefit, if the risks are far worse than the benefits, you have to forego a lot of those so-called safety measures. So the good thing about the cloth masks is that they can be tailored to size and they're washable, right? So and of course it can be done in such a nice way that kids have fun wearing them. As I had a good picture of that, could probably bring it up again.
So the question was on one of the slides. There was the acronym RVR that somebody wanted a clarification on, and a question about a mask.
Okay, well, let's just go to the mask. But I don't see the RVR. Yeah, look at these masks. These masks are like the mom herself. And I can understand the WHO concern about suffocation in infants. Of course, supervision has to be the key. And if you're at home locked in, a kid of that age would not be wearing a mask. This is because they have come out of the house into a high-risk area. That child is wearing a mask. I'm trying to find the slide with RVR, but I'm not seeing it. Or the RSV. Maybe the RSV, not RVR.
It is probably RSV, yes.
Respiratory syncytial virus. It's one of the common causes of the flu. And pneumonia in small babies, RSV. Syncytial, respiratory syncytial virus.
Okay, great. Thank you, Dr. Persaud. I see that Dr. Narendra Singh has joined us again. So, Dr. Singh, can I hand over to you again? Thank you very much.
I apologize, guys. Shanti, could you direct me where you lost me?
I think we lost you from the takeaway. You were just getting over
Okay.
to, yeah.
Okay, no problem. And the screen is okay, it's shared fine?
It's shared. Go on slideshow. Thank you.
Okay, no problem. Okay, I apologize for that, folks. So we did the takeaway message. Let's now focus on triage and treatment. So one of the things that the Chinese and the Americans have done is they've categorized it into 4 categories. One of them is the asymptomatic or mild cases, then the moderate cases, the severe, and then the critical. So 90% of patients will fall into the asymptomatic, mild, or moderate category. And for these kinds of patients, what you have to assume is that if they present with any one of the symptoms, given the fact that we're in this COVID pandemic, you don't have testing, you have to assume that they all have COVID and protect yourself. Provide symptomatic treatment for them. Many of them will either have a bit of wheezing or sometimes they already have underlying asthma. The way to treat them is not by nebulized Ventolin or nebulized albuterol, but rather use the metered dose inhaler, because the nebulized treatment will actually cause a lot of aerosolization of the virus. It's really important that when you send them home on MDIs as well. Most of these patients can be discharged, and it's better if they went home rather than being in the hospital, which would likely spread the virus more. It would also necessitate your healthcare providers using a lot of the PPEs to be able to look after these patients, to do your best to send them home, obviously if it's safe to do so. And if you do send them home, make sure they're in isolation for 14 days, particularly isolate them from the elderly or individuals who have any high-risk illnesses. Let's now focus on the severe or critical patients. All of the COVID positive or COVID suspected patients should be admitted to an isolation room. Preferably if you have a negative isolation room, that's the place to admit them. They should all have x-rays and blood work and viral studies as well, if those are possible, because many of them will have an intercurrent virus, whether it be the influenza virus or human metapneumovirus. If you don't have the ability to do that, then at least a chest x-ray and some basic blood work should be done. As Dr. Persaud mentioned, some of these patients will be having vomiting and diarrhea. Make sure they're adequately hydrated. We do recommend, particularly if they have infiltrates on the x-ray, we do cover them with broad spectrum antibiotics. If some of them come back positive for influenza, we do start them on Tamiflu as well. This is the kind of group of patients that will require oxygen. So I usually recommend just oxygen by a nasal cannula. Keep the SATs above 92%. If you can't keep the SAT above 92% and they're not working really hard at breathing, then I would recommend a mask with a rebreather capability so that we can get the inspired oxygen much higher. Again, in the hospital, if you have to give bronchodilated therapy, do not give it by a nebulizer. It's important that if it's given, it should be given by MDI. And this is very, very specific to COVID, as opposed to most other viruses. COVID is probably the one that you should think more often about using an MDI. Let's move on to the ones that, let's say you admit a patient and you start an IV, you gave them antibiotics, they're requiring more and more oxygen and they're starting to work harder at breathing. This is the situation where we recommend, and very often we use the high flow nasal cannula. For those of you not familiar with that, it's a very simple circuit, which I'll show you shortly. It's heated and humidified air and oxygen. And the cannula that's used, it's usually specialized cannula that takes up about 2/3 of the nares. But if you don't have the specialized cannula, you can use a regular cannula, but make sure it doesn't completely occlude the nares. This is what the circuit looks like. As I mentioned, the nasal cannula should be about 2/3 the diameter. Many companies make them specifically for high flow. This is the circuit. It's humidified and heated. This is your flow meter and your oxygen delivery. So basically, you adjust your oxygen, your flow meter, and you keep your temperature at an appropriate temperature around 37 while you deliver the high flow. Now, what's the benefit of high flow? So what you want to do when you have patients who have COVID or in significant respiratory distress or having issues with oxygenation, clearly you want to improve the oxygenation and you want to improve the ventilation. That's more oxygen in the system, less CO2. So the way to do that is when you deliver oxygen that's not high flow, as you can see from this diagram, if you give 6 liters by nose, they are inherently breathing in 20 liters. When you go down to the oropharynx and in the lungs, that becomes diluted, and therefore you get closer to 21% oxygen. With the high flow system, if you're giving an adult, for example, 60 liters per minute at 45% oxygen, and they're breathing in by mouth 20%, what you're going to get here is a lot more than room air because you're giving a lot more flow at a higher oxygen. We switch over to this diagram. How does it improve removal of carbon dioxide? When you're giving high flow through the nares, and we normally fully expire, when we fully expire, we still have about 1/3 carbon dioxide within our respiratory tract. What the high flow does, it actually washes it out at the end of expiration, and it fills it up with fairly high level of oxygen, depending on what you've dialed in. So as you take a breath after expiration, instead of rebreathing carbon dioxide, you're actually rebreathing a higher level of oxygen and a lower level of carbon dioxide. So that's the principle of high flow. If you don't have a high flow in your hospital right now, it's a good investment because it not only will help with your COVID patients, but it'll help with a lot of your other broncholytics down the road when you do need to manage them. What do you set your high flow at? Generally speaking, we set it at about 1 to 2 liters per minute. We start off at 1 to 2 liters per minute per kilo. And as we notice the work of breathing improving, then we try to titrate it accordingly. So if we're at 1 liter and we find that the child is still very tachypneic, there's a significant effort at breathing, then we would increase it up to a maximum of 2 liters, up to a maximum of 25 liters per minute. We generally start off at about 40% oxygen and then titrate it up to keep the stats above 95%, 92%. We use MDIs that I've talked about. All staff, when caring for patients with the high flow nasal cannula, should wear the full personal protective equipment. And lastly, even though you're delivering high flow, the patient or the child should be wearing a mask. And I'll show you exactly why. In this slide, this is a child that's wearing a mask that we're delivering high flow. This is a child that doesn't wear a mask when they cough or they sneeze. So you can see the aerosolized particles are there without a mask. Similarly, if you're just using regular oxygen with a mask, this is what you see. This is what you see without a mask when they cough or they sneeze. So it's really important when you're giving high flow or any form of oxygen, ensure that the patient or the child has a mask to protect yourself. Let's go on further. Let's say, for argument's sake, your patient gets worse and the patient does require intubation. This little contraption on the right side, some really smart guy came up with this contraption, which is essentially a glass box made of plexiglass, essentially, with 2 holes where the anesthetist can actually put their hand in and safely intubate the patient. He's using a video bronchoscope or a video laryngoscope to intubate the patient. Often we don't have that in developing countries, so we can use just a regular intubation with a laryngoscope. I've got a number of these made for our frontline staff in Guyana It's very simple to use, and I would recommend it. It's fairly inexpensive, but it does protect the staff very well. So let's move on to the techniques of intubation. And I'm only going to talk a bit about the specific things we need to be concerned about when we have a potential COVID patient or we have a positive patient. All staff should have full PPE during intubation. We should make sure that we have the most experienced person, whether it's an anesthesiologist, a neonatologist, or a pediatric intensivist, because you don't want to have multiple attempts at intubation. We do not recommend bag and mask ventilation before intubation. This is normally what I do before I intubate any other patient, but these patients, we do not bag and mask. We just put a seal on and we deliver 100% oxygen to try to pre-oxygenate them before we intubate them. And the reason we don't want to bag and mask, obviously, is because we don't want to aerosolize their secretions, which put us and our staff at risk. We should be using cuffed endotracheal tubes. That's preferred. Reason being that if the tube is uncuffed and there's a leak around the tube, again, the virus becomes aerosolized as well. Once the child is intubated, we must use bag, but we should use a bag with a filter, again, to protect ourselves. And lastly, once we've intubated the patient and we're going to switch them over to the ventilator, ordinarily we just take the bag off, we put the ventilator tubing on, and we set up the ventilator. But in this case, what we recommend is clamping the tube. Because if you take the bag off and the child coughs, that again, it aerosolizes from the endotracheal tube. So clamp the tube first and then hook up the ventilator. All of these measures here is really, if you think about it, protecting yourself. It has very little to do with what's best for the child. It's really about protecting yourself. Now, once we've successfully intubated the patient, we need to do what we talk about is lung protection. So we use low tidal volumes at about 6 to 8 mils per kilo. We try to avoid very high peak pressures if you're going to pressure ventilate the patient. Try not to get above 30 centimeters of water. And we start off at a moderate PEEP. Unlike adults, we start off at about 6, and depending upon the oxygenator, we would titrate it up or down accordingly. We then, if we have the facilities to do blood gases, try to let the principles of permissive hypocarbia guide you. Accept higher CO2s because they can tolerate it better. Because what you want to do is you want to accept higher CO2s so you don't have to give them higher pressures and higher volumes, which clearly is not good for the lungs. We recommend, when possible, if you're having trouble with oxygenation, turn the patient over. The prone position has been shown in many studies to improve the VQ mismatch, and it improves oxygenation. If you're not having trouble with oxygenation, leave the child as is. We recommend inline suctioning so that you don't aerosolize it as well. And as we talked about before, MDIs in the circuit is essential to protecting yourself. So, in summary, as I've demonstrated to you based on the 2 major studies that are out right now, COVID in kids is a very, very mild disease. Beware of the high-risk patients, which include infants and patients with comorbid conditions such as asthma, etc. Protect your staff. Many of the measures that I've talked about in the presentation today goes towards protecting the staff more than anything else. This is a slide that I made, a picture we took about a year ago during my visit to my friends in Antigua. I don't know if we have anyone on the line from Antigua, but these are some wonderful, wonderful people that I've been working with to help them with their neonatal intensive care unit, as well as to develop their neonatal nursing training program. This is a very telling slide based upon the fact that over the last week, it's become apparent to people in the United States that people of African American descent are at highest risk for significant disease and death. So as I reflect on this picture and I reflect on our people in the Caribbean, we need to be extra vigilant and extra cautious because this picture really represents much of the demographics in the Caribbean. I thank you, and thank you for the opportunity to speak to you about the COVID virus.
Thank you very much, Dr. Singh. Another excellent presentation. I will move ahead at this point with the questions. We have a few. So the first question, given the similarities of the clinical pathology of COVID-19 and cystic fibrosis, are there treatment modalities which are used in cystic fibrosis that can be applied to COVID-19? This is a question from Dr. Beckford, a pediatrician in Kingston, Jamaica. Anyone, Dr. Singh or Dr. Persaud?
I'm going to let Nar answer that one, because cystic fibrosis is basically a Caucasian disease, and he would be seeing a fair amount of those. So I think it's better if he deals with
it. To be honest with you, there is, of the patients that we have reviewed and the data that I've looked at, and lots of data coming in right now, there's no evidence that any of the treatment that have been used for cystic fibrosis would be beneficial here. Much of the treatment that we're using for the COVID patients are really supportive care. So it's basically just supportive care until such time as the ARDS or whatever pathophysiology is going on does resolve. We treated the current infection, which you would do with cystic fibrosis, mucolytics and all of that stuff that we do use sometimes when we have the cystic fibrosis that are intubated, but we haven't actually had to use that. The patient that I currently have on the ventilator in my ICU is actually a 22-year-old child with cerebral palsy who has a history of recurring aspiration. She's been intubated probably for about a week, and she's almost ready for extubation tomorrow. So there's no really good information out there about whether or not treatment for cystics would be beneficial for the COVID patients. I don't think we have the numbers yet to answer that question.
Okay, thank you, Dr. Singh. Here is a follow-up question. I think you mentioned children being able to transmit via having passed stool, that there could be virus in the stool. The question is that, does this mean that the virus can be transmitted through our home sewage system?
That's a very good question. So despite the fact that the virus appears in the stool 4 weeks later, there are no studies that have actually shown that the virus that's in the stool is still infectious. They've just actually found it. So we really don't know that answer as yet from the preliminary data that has come out. Whether it'll remain in the sewage for an extended period of time, it's really hard to say. Every day, new information comes out. As Dr. Persaud had mentioned, when this first started, we didn't think that aerosolized modality was a way of transmitting the infection. We thought it was just contact and droplets. Now that information is changing. We used to think that it was 6 feet. It's not 6 feet anymore. If you're running or you're exercising or walking outside, somebody coughs, the distance is even longer than that. So despite the fact that we found it in the stool, I would suggest that people who are taking care of babies that are not quite toilet trained, be careful to wash your hands and make sure you don't participate in the fecal-oral transmission of that virus.
I would just like to add something to that there. We should look at this here not only in a negative way, but remember, if the disease, if the virus remains in the body for a long enough period, then the degree of immunity is higher. We have seen this with typhoid. In the days when we used to treat typhoid with chloramphenicol, if you remember, it was 10 days after the fever normalized. That's about 14 days of chloramphenicol. And what used to happen there was that we never used to get rid of that bacteria fast, and the immune system had enough play to create a massive immune response. So nature is taking its course. The children are shedding this virus after a long period, but at the same time, we're working up a species immunity against this virus. is going to come again, one form or the other. It's going to resurge maybe the winter months, in the autumn, who knows? And we need herd immunity. So whoever's gotten over it, they're going to be the next barriers. They're going to be the next. They're going to be the protectors. They're going to reduce the index of infectiousness of COVID for us.
Thank you, Dr. Persaud. Thank you, Dr. Singh. The next question: what recommendations would be applied in the case of a breastfeeding mother who suspects she may have COVID symptoms?
Recent studies came out showing that it doesn't pass through the breast milk like that. So in a situation like that, wearing a mask would be the best. Of course, wearing a mask is not 100%. So it would perhaps be the best thing to do to give the baby, remove the baby, isolate the infant from that parent. Because so the highest mortality is in the infancy, if you notice.
So the studies that are out right now that looked at that show that there's no virus in the breast milk that's being excreted, that there is some question about vertical transmission from mom to baby in utero. There's no virus in the cord blood, in the umbilical cord blood, and there's no virus in the vaginal secretions from mom that have viruses that are positive, that are COVID positive. The American Academy came up with some very clear recommendations that if you suspect mom has COVID or that she is positive, the AAP actually recommends that you separate the baby from mom and that you not allow mom to breastfeed the baby physically, but actually separate, express the breast milk and feed the baby separately from the mom. Now, if that's not physically possible where you separate the baby in a different room, what they recommend is that you should separate the baby about 6 feet plus apart in a bassinet, but ideally an incubator, and you express the breast milk and give it to mom. When should you then allow the baby to come to mom? So you should allow baby to come to mom if you're able to have 2 positive or 2 negative tests 24 hours apart for both baby and mom. If mom has had symptoms for in excess of 7 days, so on day 7 to 8, you can actually put the baby back with mom. Or if mom has been fever-free for 3 days. So the AAP have some fairly clear guidelines about how to manage them. In Canada, it's a little bit different. We're a little bit more liberal with that, but that's the guidelines that we follow here in America.
Thank you, Dr. Singh. Thank you, Dr. Persaud. Here's a follow-up comment to your answers to that question. One participant is saying, please note that the World Health Organization recommends continued breastfeeding when mothers are COVID-19 positive. With the recommendation, they're saying practice respiratory hygiene and use of other PPE measures. That's just a comment from one of our participants, if you'd like to react to that.
So that's where Canada is following those guidelines, is they still allow mom to breastfeed with an appropriate PPE, an N95 mask, washing their hands, etc. In the United States, the AAP has come out with a slightly different guidelines. So that's what it said, and as you clearly identified, the WHO is a little bit more liberal with that. We haven't seen any newborns in China that have actually died from being COVID that have had COVID infections. But what they have shown is when moms pick up severe COVID disease, there's a higher incidence of premature labor. Babies who are born premature obviously have more respiratory distress, but that's more secondary to the premature labor rather than the COVID disease.
Thank you. 2 questions, one on reinfection and one on the use of hydrochloroquine. So 2 participants are asking, what's the science on reinfection, and have you seen any case of reinfection in children? And secondly, what are your thoughts on the use of hydrochloroquine in critical children? Is it recommended? Is there any evidence for use? And what is your opinion about hydrochloroquine to treat COVID-19? So reinfection, hydrochloroquine.
So the data in China and the United States is relatively new, and there haven't been any documented cases that I know of in the pediatric population where there have been reinfections. We're assuming that they develop immunity and they wouldn't get infected again. Now, whether that immunity is finite, so in a month or 2 or 3 months, once their antibodies plummet, are they going to get infected again? We really don't know that as yet. With respect to chloroquine and azithromycin, there are some protocols in North America with critically ill pediatric patients that are in vents that are using chloroquine and azithromycin. But as you all know, the studies that have been out so far, including one that came out today, they're not double-blind control studies. They're anecdotal studies, and real studies have not been done to demonstrate the true efficacy of the drugs. But there are protocols that are still using it. Until such time as the double-blind studies come out, people are not taking chances. Many of the protocols have chloroquine in it and azithromycin. Now, I do know, and I'm not sure for the rest of the Caribbean, but many physicians in the developing countries are taking chloroquine prophylactically.
Dr. Persaud, would you like to add anything before I move on to the next set of questions?
Not really. The whole question about reinfection, we have to wait and see what will play out. Of course, I'm just like to reiterate that nature has to take its course, especially with shedding and the length at which they shed the virus and so on, because contact time is very important for the immune system to kick in. Remember, the immune system is there to clean up. You know, it will reach a peak and it will clear that virus out. So there might be a shedding period, and then eventually there will be a high enough level of immunity that will actually clean the system out completely. So we just have to wait. A lot of these questions are quite unanswered. We can just be academic and say things that sound intelligent, but we will have to wait for a lot of things to play out.
Okay, great, thank you. The next question, in the case of resource-limited settings, what are your recommendations considering 1, frequency of testing to demonstrate viral clearance, and 2, fluid therapy in the absence of shock, given that aggressive fluid management may worsen oxygenation?
The intensive part, I'll let Nar deal with that because that's his bread and butter. Coming to the first part of the question, what do we do with respect to testing? Now, the testing part is the part that's beating us the most because we cannot identify, isolate, do the contact tracing because we don't have the luxury of the kits. So we'd have to work along the line of prevention, and we'll have to work at a high index of suspicion. And if people are clinically COVID and they're mild, moderate, we may have to economize on some of those kits that we have, and don't just test routinely. I mean, we cannot afford to do what South Korea did. Hopefully, when the peak is over and there are lots of surpluses in the richer countries, some of that will filter down to us. So in the meantime, as Nar would say, you have to kick the can down the road. You have to flatten the curve and just wait, because we might be fortunate to have some hand-downs or at least of cheap kits from the surpluses of the richer countries as they need them less.
So with respect to the second part of the question about IV hydration, about 30% of them, based on the data, will come in with a history of vomiting in addition to fever and coughing. So it's important that, you know, you bolus them with a bit of normal saline just to keep their hydration up a little bit. Having said that, if they start to run into trouble in terms of respiratory distress and they start having evidence of ARDS, then you're not going to liberally give them a lot of fluid because you can make the capillary leak much worse. So I would recommend not necessarily fluid restriction, but I would keep a decent and a normal fluid balance, because you do have to keep their hemodynamic state stable. I would also keep in mind the fact that many of the kids or the cases in the adult population, a lot of them are developing myocarditis. So it's not just about supporting their intravascular volume, it's about keeping in mind the fact that a lot of them might develop myocarditis. So instead of pushing too much fluids to keep their blood pressure up, give some thought to the fact that if you're having trouble with the blood pressure, it might be an element of myocarditis, in which case they may need some inotropic support. So I wouldn't give them way too much fluid. I would keep in mind the fact they may need some inotropes sooner rather than later. And if you have the ability to get an echo and look at their cardiac function, that might shed some light as to whether or not you're dealing with a myocarditis.
The next question. So one of our participants just described a recent case of a 6-year-old who died in a community and was placed in the cold room. It was stated that a reliable result for COVID-19 could not be had. And so the question is, why is this so? And does that mean that the virus dies when the host dies?
There's a period in which the virus will still be alive in that person. So body fluids can be taken, swabs can be taken, and so on. It's obvious that the virus won't die immediately. The fact that the person was put in the cold room, that would have definitely influenced the harvesting of the virus in the swabs that they were doing. Now, as to whether this 6-year-old child, and I know the child came out from Linden, whether that child died from COVID or not, it's going to be debatable because even if it's COVID, there are quite a lot of, I see a lot of patients from Linden who are asthmatics, and that's because of the mining aspect of their of where they're living. There's a lot of dust in Linden and quite a lot of asthmatics. So could very well be a COVID case compounded by asthma. It's kind of strange. Let's hope that they managed to do something with respect to testing that child.
So I'm not sure what testing capabilities are available there, but if it's a PCR test, then it's really looking for an antigen. And whether the virus is alive or dead, it should still be picking it up because you're looking for an antigen. So whether you pick it up in the nasal secretions or they did a postmortem, it should be in the lungs, it should be in the tissue, and they should be able to pick that up on PCR. So I'm not sure why.
Yeah, the contention was that they put the child into the morgue, and that they felt that could have negatively influenced.
Should still be able to pick up the antigen. Because if the virus dies, it's still an antigen.
Correct. So if you follow-up questions, there's one on the issue of this tool again, and one participant would like to know, how does this translate into some practical guidance? Should, for example, covering the toilet bowl when you flush? So more practical question. Another practical question, one participant would like to know what special precautions they should take when handling laundry for suspected COVID pediatric patients.
I think the laundry for pediatric patients and for adults would be the same, right? And of course, we bear in mind that things like, depending on the type of fabric, of course, COVID will remain on fabric for hours, days. So if you touch the laundry, once it gets into the washing system, whether it's a tub of detergent or whether it's a washing machine with detergent, we know that's going to kill the virus. So just make sure that you wash your hands after touching dirty laundry before you touch your face. Coming back to that question of shedding, fecal-oral. While we're exercising all of these hand washing techniques and so on, it's perhaps a good thing because we expect not to have much gastroenteritis during this outbreak because of the hygiene. So with good hygiene techniques, I don't think the fecal-oral route is going to be so important, especially if there's running water available to most of the population. once we continue to encourage hand washing, proper disposal of Pampers, of course, it's good if people can be aware that there is such a route of extended shedding. So they continue to take the basic hygiene measures of washing hands before handling food, before eating, and after handling Pampers and food and all of that, wiping down the toilet bowls and whatever else they have to do.
A few more questions. So one of our participants, Dr. Singh, would like to know if there are references confirming children acting as vector, and if they are, whether you can share those. I can forward those to the participants.
Sure.
Thank you. So what is the guideline for physiotherapy in pediatric COVID patient with respiratory complications?
So if they are, for example, on high flow and they're in respiratory distress, we try to avoid as much as possible physio, because obviously that actually aerosolizes the treatment. Anything that would put the healthcare providers at risk, we try to limit it as much as possible. Now, if your child is very congested and you have to do it, the key is to make sure you put a mask on them if you're giving high flow, because they're going to be coughing, they're going to be sneezing sometimes when you do give chest physio. But if at all possible, I would limit the chest physio if you can. And use a mask if you have to.
Okay, great. Thank you. So we have a question from another participant who is asking, why are children reacting better to COVID?
Remember with the beginning slide there, we showed some spikes. The spike on the virus actually gave it the name, the coronavirus. Well, it's being postulated that children, for some reason, their anatomy and physiology, have fewer receptors in the lungs that allow those spikes to connect to the cells that are infected. So that is something we will definitely know more about. But the anatomy and the physiology is such that children don't receive the virus that well in the lungs. A lot has to do with inoculation, the amount of inoculation that occurs also. If you have a few viruses entering the respiratory system of a child, maybe it will be difficult for that virus, the viral spike, to connect with the cell that it needs. So the inoculate is very important, the quantity of viruses that enter into that child.
So there are a number of theories out there, and that's one of them. The other theory is that as you get older, your immune system actually becomes very robust. It becomes stronger. And by getting stronger, what happens is that it reacts much more. So there's much more of an inflammatory response to the virus in the lungs, for example, because your system is so much more robust. Whereas in kids, because their immune system is not as well developed, they don't have as much of an inflammatory mediated surge as the adults do. So that's one of the other theories that's out there, that kids don't have as good an immune response. And the robust immune response is to the detriment of the adults.
Mm-hmm.
But there are a number of other theories out there as well.
Yeah. Sorry for the fun, overkill.
So I would like to ask two of my own questions, Dr. Singh and Dr. Persaud. Can you share your thoughts with us on this discussion or conversation that's happening around the protective factor/mechanism of BCG? And my second question to you, Dr. Nar, you had a slide where you said that 62%, I think, of infants among all children who are hospitalized, 62% are infants, and that the children who are showing up with moderate to severe illnesses are the ones with comorbidities. Bringing the two together, can you share what are the comorbidities that you're seeing in children?
So let me answer the second question, and maybe the first one I'll leave to Hardat as well. So the ones that we're seeing, or they seem to be seeing, is the kids that have asthma, the kids who have cerebral palsy, who have recurring aspiration syndrome, so then a lot of them have a bit of a scarring of their lungs. Any kid with chronic lung disease, The second group that we're seeing is kids who have had cardiac surgery, so cardiac disease, congenital heart disease that have been repaired, some that haven't been repaired. The third group are the patients that are immunocompromised, so kids who are on immunotherapy for whatever disease they have, or they've also documented a number of patients who have cancers, like the leukemics who are on chemotherapy. They seem to be the big ones that are in that mild to moderate category in terms of risk. And the infants, of course, are the ones less than a year of age. Now, we do know that infants less than a year of age, irrespective of whatever virus is it, whether it's influenza, human metapneumovirus, RSV, or COVID, they're invariably, a large percentage of them develop bronchiolitis anyway. So that's not unusual in that population. But the other ones with the comorbid conditions are the ones that I just mentioned.
Okay, thank you. And if you can both share your thoughts on the BCG.
The BCG, this is a new, this is something new. It came out about a week ago, and out of India, basically, because if you know, India is a country that still is ravaged by TB, and to prevent early death from TB, disseminated forms of TB, certain countries are still giving BCG. We happen to be one of those countries. So a lot of studies have been coming out of countries like India. Not studies, but noticeable moments in their statistics that point towards the fact that the widespread use of the BCG vaccine has had some positive influence on the morbidity and mortality. For the time being, it's like more or less anecdotal. And we are just hoping in this part of the world that there's something, some merit in this hypothesis or theory or conjecture or whatever you want to call it, and how hopefully we will benefit from this.
So I saw a couple of studies talking about the BCG vaccine being protective, and the theory behind it is that the antibodies that it does produce is somewhat protective against the coronavirus to some extent. I think time will tell, because India is now in the middle of the coronavirus pandemic. They are not seeing the kinds of numbers as the other countries in Europe, for example, but they've also been on lockdown for a little while as well. So there are many variables that are involved aside from just the fact that they've gotten the BCG vaccine and Europe hasn't. There's some other variables that are involved. So it'll be hard to weed that out to the end of the day. But I think all of the Caribbean islands and Guyana, we're all hoping and wishing that the BCG vaccine is protective, including myself, that have this big scar in my deltoids many, many years ago. So we're all hoping that it's protective, but we really don't know for sure.
Not sure, yeah. Of course, the effect of the virus on your pathophysiology is a cascade, and somewhere along the line, maybe the BCG has managed to produce something that throws a wrench, a monkey wrench into that whole mechanism, at least to some degree. So let's hope that we'll have a milder course of this illness in this part of the world.
So I just received 2 questions very quickly as a follow-up to the comorbidity question. So specifically in terms of the immunocompromised patient, in relation to the immunocompromised patient, one participant would like you to confirm that this does include children exposed to HIV. And the second question is, have you seen an increased risk of serious COVID-19 in children with overweight, obesity, and/or diabetes? These are increasingly mentioned as risk factors for adults.
I think at this point in time, we can only speculate because that data is not out yet. And even though they're giving us some data, they're not getting into the weeds of some of the stuff. So for all intents and purposes, I would assume, with not much evidence, given the fact that they're immunocompromised to begin with, that they should be treated with kid gloves and made sure that we take necessary precautions to protect them even more. With respect to the other comorbid conditions, there was a second question. I didn't get that.
It's in relation to obesity, overweight, diabetes, whether these are factors that you're seeing in children because they're increasingly mentioned as risk factors for adults.
Yes, so we haven't actually gotten that data as yet. Again, we're getting gross numbers in there, but we certainly haven't seen diabetes as an issue or obesity as an issue yet. I suspect the adolescents or the teenagers might be down the road, but that data is not out yet. Remember that there have been 1.5 million cases around the world, and so far the only reports we have on kids is it's about 4,500 out of 1.5 million. So the data on that stuff is not quite out yet.
Okay. Thank you, Dr. Singh, and I'll mention one comment that just came in. One participant wants to say thanks to both you and Dr. Persaud for facilitating and sharing some really insightful experiences and knowledge and answering their questions, and hope that this can be done post-pandemic to talk about some of the lessons learned. And I think that's a good note for me to really end the webinar, bring an end to this. So thank you very much to our presenters, Dr. Narendra Singh and Dr. Hardat Persaud. Thank you so very much for providing really comprehensive presentations, sharing your expertise as well as your experiences. Thank you very much, colleagues, for participating, for joining us. I trust that you would have gained new knowledge that you'll be able to use in your work. I will share the PowerPoint presentations with you shortly. This brings us to the end of the webinar. Please stay tuned. We'll be ready to share more new knowledge as this becomes available to us. A blessed Good Friday to all of you, and have a good afternoon.
Thank you.
Thank you very much.